Thank you, Kristen, for inviting me. This is the second time I'm getting to talk to teachers, and I think it's just such a nice group because you guys have such an impact and reach, to the next generation of people who would probably go into science and deal with some of the questions that we're going to talk about. To keep me on track and honest, I have an outline just to make sure that I stick to what the goal of the talks today are. So we're just going to go through some of the wordings. A lot of you are biology teachers, so the things that I'm going to talk about are not new to you, but just so that we are all on the same page. After doing the logistics, we would talk about why talk about genetic testing? Why is it different from other forms of medicine, or is it the same? Then we would go through some of the advances in genomic testing that have come about in the last 10 years, or 12 years now. Talk about the challenges, and I have a series of 6 actual patient cases that I would go through to illustrate the challenges that we are dealing with, and then come back to saying that, okay, so we have recognized the things that need to be done. What are the initiatives that are countrywide, international, that are being taken to deal with these questions that are posed in front of us? I have spent a lot of time thinking about these challenges, so I get carried. I start talking about those more, but I want to make sure that we all understand that genetic testing is needed and is a very powerful tool that helps people in multiple ways. So even though I'll spend more time talking about challenges, I want to make sure that it's not all scary and controversial. All right, so to talk about genetic testing, we just would go through some of the basic genetics pretty quickly. Genetics, genes are what makes us how we look, how we function, makes us different from each other, etc. So genes are present in each one of our cells, and these are located in chromosomes. And we have 2 sets of 23 chromosomes in each one of our cells. Males have XY, which is what makes them male, and females have 2 X chromosomes. We just some cartoons that I think are so cute and really make the point of what the genes and DNA are. So genes reside on chromosomes, and they are made up of DNA. And there are parts of the chromosomes that are genes, and then there are parts that are just some DNA. What it does, it's made up of deoxyribonucleic acid, and there are about 4 bases, and then there are order of it, and they go in particular order, and these order form like recipes. So they tell you the cell, now you're going to be a brain cell, or you're going to be a hair follicle, or you're going to be a heart cell. So that's really what genes do. Given that they are really the blueprint of instruction, if there are changes in it, like in a recipe, if you have a typo or if you have a missing word, it's not going to make sense. Similarly, if there are changes in genes, what we call mutations, that can result in medical conditions. So here, let's see if I can make this work. Okay. All right. So we have chromosome X here, and there is a gene called the FMR1 gene. The alterations in this gene results in a mutation that results in a condition it expresses in males called Fragile X syndrome. Have you guys heard about it? It's one of the more common genetic conditions in males with intellectual disability. But apart from intellectual disability, as you would see, all these males also have characteristic features. They all have elongated face, they all have kind of larger ears. So it's one of the common genetic conditions, but this just goes on to say if you have changes in genes that can result in medical conditions. What we have known over the years is not all changes are bad, not all changes cause disease. And so when we do genetic testing, a lot of what we do is identify the changes and then try to figure out which ones of these are causing a condition. And just to make sure that we are all on the same page, when we talk about genetic testing, there is clinical testing that is ordered by a doctor or a healthcare provider, and then there is direct-to-consumer testing. We're going to be talking mostly about, primarily about the clinical testing. I'm not talking about the direct-to-consumer testing because that's really my area of expertise. And the clinical testing happens in multiple different scenarios, and the diagnostic testing, so there was a child who comes in and you're concerned about Fragile X syndrome, so there will be the diagnostic testing to confirm that. And we will talk about how that has really changed and evolved into that you don't necessarily have to suspect only one syndrome, you can do more broader testing. There's also predictive testing, the screening test to say, do you have a risk for a heart condition? There's pre-symptomatic testing, so if there is family history of cancer or a heart condition, then even before an individual starts to present symptoms, the testing can be done to see if they necessarily carry the genetic change that may predispose them to that condition. There is testing that's done in prenatal or preconception setting, a fetus that is presenting with ultrasound features concerning of structural changes or again with family history. Newborn screening is done, and that, the heel stick, and a lot of you might have personal experience with it, and that is really done to limit morbidity and mortality, because you can start treating some of these conditions even before you recognize them clinically. There is carrier testing, and then the pharmacogenomic testing, which really is the up and coming part of genetic testing. So we can look at some markers and see how certain genes metabolize some drugs. Some people are fast responders, some people are slow responders, sometimes there are side effects. So this group of markers that you can test really helps in physicians in ordering correct kind of medication, and it has a lot of promise, but we are in infancy of pharmacogenomic testing. So that's really the outline, and again to remind you that I'm talking about clinical testing, and I'm not going to go into the direct-to-consumer testing, which has its own challenges. So we talk about genetics. What's so special about it? Well, maybe because it's everywhere. So these are some, over the last few years, Time magazine has published articles, and this was really interesting. We have been saying this for a few years now. Future is now. It does really feel future is now. But Angelina Jolie, who underwent bilateral mastectomy because she had mutation in one of the breast cancer predisposition gene, and so it's everywhere. So apart from the media, what is the burden of Mendelian genetic disorders? So they're rare. We think about genetic conditions not being common. We're not going to come across it. The truth is they're individually rare, but not collectively so rare. We know that there are more than 7,000 different medical conditions that have a suspected Mendelian inheritance. More than 13 million individuals, sometimes people go on to say as many as 1 in 17 individuals in the United States have predisposition to some genetic condition. All different genetic conditions account for 20% of infant mortality. Of about 20% of all hospitalizations that happen are due to genetic conditions. So these are really widespread, We may think it's rare, but not when you put them all together. Being a tertiary care center, about half of our inpatient admissions are for individuals who have various genetic conditions. So just knowing that there are so many different genetic conditions, it's also interesting to look at how many of these have tests available. There are about 16,000 different tests available as of August of 2014 for 4,200 conditions, and those are for 2,800 different genes. Most of these tests are still in research arena and not in the clinical setting, so not all are available to everybody, but the numbers in the past year have really skyrocketed. I mean, I was just looking at the graph, and we are on definitely an upwards trajectory. So as I was saying earlier, so what happens when you do genetic testing? What comes out of it? We can't fix the genes yet. it ends diagnostic odyssey. In my own experience, there are families that keep coming back every 2 years trying to figure out, well, why is all that's going on with their child? The child has a heart condition, has developmental delay, has eye abnormality, and we're trying to figure out what's causing all of this. So it ends diagnostic odyssey. It is really empowering for families to know what caused their child's condition, and it wasn't something that they could have done or not done that would have changed really the medical history of this child. Exact diagnosis, finding it really helps deciding what the treatment is going to be. And even though we don't have all treatments for all genetic conditions, we know how to manage them. But really understanding what causes it has helped us finding cure for at least a handful of genetic conditions. It is very helpful in understanding what to expect from this child. We can compare other people, a group of people who have had the same condition. Are there other things that they need to be worried about? Would they need any kind of screening or treatment? So it really helps in prognostic information, but also for families to come together and talk about it. It's just really empowering and helpful. Recurrence risk counseling. Most families want to know, well, this happened once, what are the chances this would occur again? Or I have a family history of breast cancer, what are my chances that it would happen again? I could tell you theoretically, if there is a parent with one of the dominant mutation, there's 50% chance. But with doing genetic testing, you can actually get down to more detailed answers. And really, this would result in personalized treatment and care. And so the goal of genetic medicines really are to be able to prevent disease for all the predisposition conditions and for personalized medicine. And honestly, in 2013 and 14, a beautiful example of personalized medicine has evolved, and that is in tumor testing. And so all tumors, there are changes in the genes in the tumor, and that really decide the course of the disease. And you can look at the markers within tumor and figure out what drugs this tumor is going to respond to and what it's not going to respond to. And the treatment can be really tailored based on the tumor genetic marker profile. And this is being used. And currently there are about 10 to 15 different genetic testing panels that are for tumor testing. And I'm not talking about predisposition testing, but actually looking at the tumor. So this really has changed how the cancer has been treated in the past, because you can really know before trying and wasting time and figuring out what's going to work. So is genetic testing much different from other medical testing, or is genetic medicine really different? We think it is. And the reason for that is genetic information affects everybody in the family, not just one person. If you have a mutation, there is a high likelihood that you inherited it from somebody, and also you can pass it on. Risks are not always obvious. It's not just the risks that are the medical risk, but also the psychological, social, and financial complications that come with it are not always obvious. It has limited predictive power because there is uncertainty. As I was saying, we can identify genetic changes very easily, but some changes cause disease and some changes do not. And we are really in between that. We can identify so much more than we can interpret. And genetic conditions, just by their nature, are not all. It's not a guarantee when you have a mutation that the next person would go on to have disease or not. It's really a lot of time risk factors. So there are all such issues that are unique, maybe not just to genetic conditions, but to a group of conditions that includes genetic conditions. They're difficult to treat. You cannot go back to every single cell and change a gene. That's still hard. But there are things that we can do. It's definitely promising. And there are the availability of intervention. So a lot of what we do currently is how to manage it, to do screen. We cannot always prevent things. So those are the realities of it, which is why genetic testing becomes slightly different from the rest of medicine. Any questions, comments? Am I talking too fast? All right. All right, so let's move on to how, since I have been practicing, how the field has changed. And I want to start with an example. So, clinical genetics evaluation. There are physicians who specialize in genetics, and there are genetics clinic. And clinical genetic evaluation has been recommended necessary for autism spectrum disorder by American Academy of Pediatrics, by American College of Medical Genetics. So we see a lot of kids like that, and given that you guys are teachers, you probably see children like that too. So what happened in 2008 in such an evaluation? So the clinical genetics evaluation, which involves a physical exam. So we do multiple measurements. So we would measure the head circumference, we look at the fingerprint pattern, we look at the eyes, and so what we call dysmorphic features, we look at the growth, we look at the height, we look at the family history. After doing that, we categorize autism spectrum disorder in 3 different categories. One of them is that autism is alone, it's isolated, there are no other features. Other times, we find that there are other things going on. Maybe there is a structural defect, maybe there is microcephaly, which is smaller head circumference, or macrocephaly. Sometimes looking at these soft signs, as we call them, we can say, well, maybe this individual has Fragile X syndrome. And so in 2008, what we could do was we could confirm this by doing the testing, and then this would again go back to answering the questions, why do the testing? Or there is a gene called P10 gene, again with larger head circumference, with autism spectrum disorder, we would do that testing, or chromosomal testing. So let's talk a little bit more about the genetic testing. There are 3 ways of doing it, and so you can either look at the chromosomes, and there could be big pieces of chromosomes missing or extra. You can look at the DNA and look at individual genes to see if you identify changes, or you can do the biochemical testing as it's done by newborn screening. So, going back to our example, so in 2008, if we were concerned about Fragile X syndrome, we could do the test for that particular gene. If we thought if this individual has Down syndrome, you could look at the chromosomes. So these are really the chromosomes lined up with their numbers, and they just, our largest one is called chromosome number 1, smallest one is chromosome, actually 21 is smaller than 22, but people made that mistake multiple years ago. But anyway, so we have that, and if you see every other chromosome is in number 2, and the chromosome 21, there are 3 of them, so that is Down syndrome. So that's how we did the testing until when we could, until the Human Genome Project was launched. And what happened with Human Genome Project, and these really shows the timeline. Is it visible? Can everybody see it? Okay. So what happened in 1990s when the Human Genome Project started, we wanted to sequence the whole genome. So there are 3 billion base pairs, and they wanted to sequence all of it to understand, the mystery of it. And it took them about 6 to 8 years in sequencing that. It took about $49 million to be able to do that. From there, when it ended, it took them 3 to 4 months in being able to sequence the genome, So the cost and the time required is reducing. In 2013, it takes a lot less money, and we can get it done in 1 day or so. And in 2015, it takes even less time. So the cost of being able to develop the data is definitely reducing. What impact did it have on the diagnostic testing? So this was all done on the research side. So what impact did it have in diagnostic testing? So in 1959, that's when the chromosomes were identified. 1986, when they could do the Fragile X testing. As the time has evolved, so we used to be able to identify, if the whole chromosome was missing or extra. In 1990s, we could identify slightly lower changes. In about 2005, so this is with the help of Human Genome Project, we could look at the chromosomes on molecular level and identify much smaller changes. When you start looking at the sequencing, so more molecular side, we could do Sanger sequencing. So you had to have baits, and you had to create the baits for particular genes and then sequence it. Now what we do is it's called massively parallel sequencing. So your baits are everywhere, you sequence everything, and then you put it together. And that has really helped. So now we can identify all those point mutations or the spelling mistakes by looking at the massively parallel sequencing, also known as next generation sequencing, and we can look at the pieces missing or extra called deletions or duplications by this chromosomal microarray testing. Soon, we won't have to do these two different tests. We would be able to do it all by sequencing. We would get all kinds of our answers through sequencing. So testing is really evolving, and we feel like it's so translation this time, because even since I have been at CHOP, which is not that long, the technology has changed and the resolution has increased. So this is just to say, this is how we look at chromosomes now. So instead of looking at it under the microscope, we look at it by looking at the DNA, and this is showing normal chromosomes, and this is plotted on the log ratio, and there is a lot of information, and I'm not going to go through, but the point here is that's the level of detail we can get through. Instead of looking at 5 to 10 megabases when there was extra or deleted, we can look at things that are much smaller now. So that's really the resolution of the technology. Then once we know where the deletion is, we can look at it, we can plug in those coordinates, and then we can look at it, what genes are deleted or duplicated. So from going from chromosome testing being an art, we have gotten to that it's very, very clear cut that there is no question about two people would interpret it differently. So the resolution has increased, and it's amazing what we can do with it. We're going towards, have you guys heard about exome sequencing? No. So with genome sequencing, what we do is that we sequence the whole genome, right? And it will generate a lot of data, but because of our capacity, we can only get so many times of that. And because, as I said, massively parallel sequencing, you have baits all over and you're putting it together, you have to have really good quality data. So exome sequencing is, instead of looking at the whole genome, you look at only a piece of the apple instead of looking at the whole apple, but we know that's where all the genes are situated. So that's the information that we can actually interpret. Even if we found information at the rest of the genome, the science hasn't gone to the point that we could interpret it. So what we do is we only look at where the genes are situated, or the expressing parts of the genes called exons. So all the exons together put together are called exome sequencing. So the times when we did Fragile X testing, that was one gene. Now we can sequence all 20,000 genes together. And CHOP recently launched this test, and the information that we get from that test is quite amazing. So going from in 2008, how the testing for autism spectrum disorder looked like, now this is how it looks like. We can do confirmatory testing still when there is a suspicion for it, but now for the other conditions, we have chromosomal microarrays available, so you don't necessarily know what exactly you have to look for, but you can do a wider test and see, are there changes anywhere, and then you look at those changes and you match it with patient's phenotype, and then you say, okay, is this what's causing this patient's phenotype or not? You can also do multiple gene panels or the exome sequencing to look for explanations for autism spectrum disorder. As of 2010, chromosomal microarray testing is the first line of testing for all individuals with autism spectrum disorders and developmental delay. And in 2014 is when insurance companies finally agreed that this was clinically required, and there was proven clinical utility. We're still dealing with it, and we won't get a chance today to talk about the insurance and the reimbursement issues, but at least for autism spectrum disorder, most people can get the testing that is necessary. Not the most advanced testing, but at least the chromosomal microarray testing, and we know about 10% of the individuals we would be able to identify an answer for their condition. All right, so moving on, the challenges of it. So there are multiple challenges as they exist. There are logistical challenges. We get so much data. Where is data going to be stored? What we have to make sure that the privacy is maintained, the insurance coverage to make sure that patients can get testing done. There are technical challenges to make sure that we really identify a change when it's present, because the technology has to be robust enough. We have to make sure that we're not there are no false positives. So basically, low false positive, low false negative. Interpretation, how well do we understand all these changes? And what complicates interpretation is the built-in the biology of it, that not all genes don't work alone, they work in concert, and that's why not everybody presents the same way. So one person who has the condition may present it differently in another patient. So variable expressivity, 2 patients with Alagille syndrome, which is a multi-system disorder. They have liver condition and heart condition. Some people would have these facial features, some people won't have it. The severity of that really changes. And the reduced penetrance, like we were talking about cancer, BRCA1 and 2 mutation, they are really risk factor. You could have up to 70% or 80% risk, but it's not a guarantee because the penetrance is not 100%. And then what happens when we find when we find more than what we were looking for? So those are all the challenges, and as I had said earlier, I'm going to illustrate these challenges with 6 different cases that I was involved with, and they are such eye-opening cases that just makes you realize that there's just so much that needs to be done. So we are in what we call a data tsunami right now. We get so much data generated from these testing, so that's right now the best career for people to take is bioinformatics, because they really help you deal with the data and how to analyze so much data. So we definitely find a lot of information, and as I said, we know that there are some things that don't cause anything, the polymorphisms and then the mutation, and then there is a lot that's in between, and we don't know how to really separate those two out. To give you an example, this is an individual that had hearing loss, and about 50% of the hearing loss is because of genetic mutations. So they did the exome sequencing, so we looked at all of their 20,000 genes at once. And we had good quality data, and then we looked at changes in the genes that match this, that are associated with hearing loss. And then, having gone through multiple filters, we still came up with close to 3,000 rare variants. So not seen in common people, not seen in unaffected people. They are present in genes, so not in the regions that are in between gene. So that's how much data we have to sieve through to see what really is causing the hearing loss in it. And so that's just the amount of data. So going back to interpretation and how well can we interpret things. So this is one of our patients. He came in with developmental delay. As you can see, he has left eye ptosis. He had syntactily, that's shown in his foot, and he had some hip anomaly, which is not as uncommon. So none of the things that are going on with him are that uncommon, right? So he had the chromosomal microarray testing done, and we identified what we call 1q21 deletion. So a piece on chromosome 1, band Q21, was missing. And so we go on to test the parents to see, so what we do when we identify all these novel changes, we do parental testing. If the parents don't have the same condition and they still have this genetic alteration, we say maybe it's not doing something. So this was inherited from the father, who is a PhD biochemist. He's a marathon runner, but he had those soft facial features, the mild dysmorphic features, which, everybody's got 1 or 2 of those, and that's just what makes us look how we look. But so he had some mild dysmorphic features, but he's otherwise doing really well. What do we make of it? So we turn to literature and see what do we know about it. So they say that it's been associated with schizophrenia, with heart condition, with developmental delay, microcephaly, macrocephaly, with variable pediatric phenotypes. Everything under the sun. So this is just we have seen hundreds of these at this point, and this has been named as 1q21.1 microdeletion of uncertain significance. So we know it exists. It's maybe a risk factor. May not produce all the features on its own alone, but it needs something else to produce features, but it exists. So there is uncertainty in the interpretation of what it does. And one of my colleagues, Dr. Marion Reef, who actually is at Penn, she's been working on understanding the uncertainty and what it impacts. It impacts people's decision whether or not to get the testing done. It impacts the perception about illness, but also about self. Do people tell other people in the family when they identify these genetic mutations? The stress that parents feel and the anxiety, it has impact on parent-child relationship, and satisfaction with healthcare. We have one master student doing her thesis with me right now, and she's really looking at the understanding. How much do parents understand when they are given these results back? So going back to the patient that we're talking about, so this is what the father said. When I looked up the 1q21 deletion, it's like a label now. Am I not the whole person? Are they going to exclude these people with this deletion? Oh well, maybe he's a little bit slow in some areas or something like that, but I am over it now. So Dr. Reeve had interviewed this father to see what impact did it have on him, and this very well achieving person who's physically fit, is PhD biochemist, questioned, did it not make him the whole person because there's something missing? And so this really, as I was saying earlier, why genetic conditions are different, because it has more than what's obvious to the eyes. So I have done a lot of my research on these unintended outcomes of it, and some of these end up being useful and some of them not so much. This was a 2-year-old female with developmental delays. So she had chromosomal microarray done, so she was sent to our lab to do the testing. We did the testing. Testing identified a deletion on chromosome 6. This deletion included a gene called DISP. It's been associated with arrhythmic heart. And some of these individuals who have this condition may just have sudden cardiac death. So, the crib death, etc., that has been seen in the past. So that doesn't explain what's going on with her, why she has the delays, but now we identified something that's totally unrelated. But giving this information back, they were able to start screening, and this may be potentially life-saving for her. So, this is a secondary or an incidental finding that possibly is helpful to the family. Here's another example so in this screen, you're looking at all the chromosomes again, and each chromosome has got 2 graphs, and the second graph is showing those pink regions. Actually, no, each chromosome only has 1 graph. I guess I removed the other one. And the pink regions here shows homozygosity. So they inherited identical segments of the chromosomes from mom and dad. How can that happen when mom and dad are related? And this was published recently because of the technology. We can identify incest. When in the lab, when we see things like that, we don't know what to do with it. We don't know what impact does it have on the patient's condition, but it goes beyond that. Do we have a duty to report it back? Do we need to tell somebody? We don't know when it's incest because of rape, if it was consensual, coercive, is there for the risk and other family members, but also the recurrence risk. So this just becomes really complicated when we identify things like that. We looked at when we have had 4 cases like that, and we looked at the legal liability. So they say that it is rape, abuse, incest is Pennsylvania requires reporting back to the state. When do we do it? There is always a whole spectrum, when we are so sure that it really is incest. So we have to have high degree of suspicion that this was incest. And then the lab doesn't see the patient, so it's really not us who goes back to them. So what we do is we work with our ethics department. The ethics department is consisted of nurses, ethicists, physicians and other people who are interested in issues like that, and they came together and they created a whole pathway for us. When we have suspicion like that, we then alert the child protection team who evaluates risk, because they wanted to go beyond that. They did not want to just report it back if it was really a not happy family, if it was a functional family, because changing that for the child, could be so disruptive. So they evaluate things on multiple different levels, and when there is a need, then they would go on and report it to the outside agency. So we don't take this lightly, because when we identify things like that, that could have huge impact. This was another example. This was a 3-year-old male. He came in because he had autism. He had language delays. He had regression of his development, and microarray testing was done as the first line of testing. And here's what we found. So the first picture in blue shows the normal reference. So this is on chromosome 15. Chromosome 15 has 2 genes nearby. One is STRC and the other one is CATSPR2. When you have 2 copies of STRC deleted, it results in hearing loss, deafness. Most individuals, because these genes are so close together a lot, and because of the genomic architecture, most of the times we see them deleted together. And when you have both STRC and CATSPR2 deleted, both copies of it, it results in hearing loss and in male infertility. In this case, what we identified was 2 copies of the CATSPR2, the fertility gene deleted, only 1 copy of STRC deleted. This patient did not have hearing loss, so this wasn't really the concern. This does not explain the patient's phenotype. But we identified that this patient would have infertility. So what would you think? Would you want to know information like this? You would? Can we take a quick poll? How many people would want to know information like this if it just... Okay.
I'm undecided.
Absolutely. So some people want to know, and some people don't want to know, and some people, it's really hard to understand what the impact is. So the consent for this testing becomes really complicated.
I like to just, because it goes back to the point that the parent made, doesn't make them a whole person. Knowing or not knowing, doing or not doing, that seems to be the question as an individual.
Absolutely. Absolutely. The benefits of this was that given the way, what causes infertility is that the sperms are not motile, but they could have biological children by doing cytoplasmic sperm injection. The harm was that we couldn't 100% say, because those 2 genes are always seen deleted together and they always result in hearing loss and infertility. We know that STRC deletions cause hearing loss, but CATSPR2 deletions were not reported in humans. So we knew by deduction, and we were pretty comfortable, but we could not guarantee it. So the benefits was that by giving this information, this person could have biological children. But the harm was, we give this information out and they think that they're not going to have children. They may not use safe practices. But so those were really the harms, but this really went beyond it, because otherwise this person could have gone through their life, had infertility, not realized what the causes, would have undergone a lot of different testing and treatment, and would not have figured it out for a very long time what the reason is. So what we did in this case, we talked to the mother and said that we did not identify the reason for your child's current issues. We did identify something that's unrelated, that's not going to impact his health anytime soon, and really is not going to impact health in the traditional sense. Would you still want to know this information? Mom said, yes, I want to know everything that you know about my child. And so we did give this information. They did understand. She was grateful, because there is something that can be done about it.
Another question related to that. I mean, so then this is where your department could interface with other departments, because when a couple comes and they have infertility, how often do they get genetic testing then? Because then you would find, and if you go back to the picture where it's the alleles, So there's the normal setup. Basically, allele 1 and allele 2, one's from the moms, one's from the dad. So
Correct.
both of those on chromosome 15, both mom and dad have that deletion of the Catsburg, which is so. And that kind of goes to another question. You said that 1 in 17 may have a genetic disorder. Right? Wasn't that one of the statistics you said early on?
Right.
1 in 17.
Right.
So basically, if
Right.
you were to do everyone's genomic sequence, I mean, are any of us honestly really, how many of us are honestly normal, perfectly normal? This just says that 1 in 17 would result in a genetic disorder that we phenotypically see. So my assumption is that everybody has something. What does it result in? Perhaps nothing. I mean, what is the perfect scenario of genetics? Is there such a thing even?
Beautiful question. It's like, really, that's really where we are. Truly, 1 in 17 individual potentially, that's the higher side of the number, could have really a genetic condition that could be identifiable if we sequenced everybody, and that's what we are really finding. We as the royal we, people in research started looking at normal people, and we started sequencing normal individuals, quote unquote normal, right? Unaffected. We started sequencing everybody and trying to identify, well, what's normal, what's not normal, and when you have a whole database of normal people, when you have people who come in affected, you can deduce that, oh, this is seen in normal people, this is not seen in normal, this might be what's causing. Of course, this is oversimplification. You look at what the gene does, etc., etc. But we just recently published a paper by a huge consortium that a lot of people have these genetic mutations. And that's really where the 1 in 17 number is coming. That's really from what we know currently. The number may also go higher. Also, when we go back to mutations, right, we say that everybody's got some mutations, recessive mutations. You're just carrier for things that's never going to express. It's not going to matter anything. So everybody's got something going on. Of course, some of this is just adding on to our diversity. Some of that is including and becoming a part of evolution. And some of this is really causing disease, as we can identify. So you're absolutely right. Is there anybody who's exactly normal? I don't know.
I'm just wondering if there's any mutations that would be good, that you would, oh, wow, that would be great. It's a fast runner or for IQ or anything.
Right, and I'm sure there are things like that. That's what really makes us different from one another. Some people are just, physically more fit. Why? Maybe because they have some alleles that have advantages. Those are advantageous, and some of them are not. And that's when, a few years ago, I remember, the designer baby was on every cover of every magazine, and people started talking about, why are we doing this? Then, we're going to terminate maybe perfectly normal, physically healthy pregnancies for all these traits because we want to play with evolution and change all these things. So going back to, I'm not talking about any testing that's not clinical because it gets, but you're right. There are genes that do give us more desirable traits.
Could you just name a few or give a couple examples?
Could I give a couple of examples? The one that we recently saw, it's not necessarily advantageous, but just to show you the change of it. We were doing testing on somebody, and we are part of a research, and the research is really to identify best clinical practices, and we said that we're not going to look at any traits, and we're not going to give you any trait information back, right? But we're looking at stuff, and one of the genes that we came up and we stopped at was a red hair gene. And I was like, okay. So we do identify things like that. What's better versus not, it's slightly subjective, but we would see sometimes, as I was talking about the pharmacogenomic stuff, people who are fast metabolizer or slow metabolizer of it. If you metabolize it slightly slowly, you don't need quite as much medication, but also if you give too much medication and you're a slow metabolizer, that's not good. So it's slightly subjective. But
And then we talk to the students about sickle cell and how that's advantageous.
Very
It's
good
just such a
example.
small 1-point mutation.
Yeah.
It's advantageous in Africa, even though it's not so much here in America.
That is a great example, and that has become a part of evolution so much, such founder mutations. So that really is because those individuals have protection against malaria, and they were able and that founder mutation, because of the bottleneck, etc., did become more prevalent. But that is a great example of it.
Does that mean that, and I'm maybe putting two things together, because you're saying that focus on the clinical information and how this is driving some choices, and in one case even to have the bioethical discussion about what to do. Is the clinical information driving the social outcomes or considerations? Because it seems like the social considerations are not really being developed yet, but as you continue to do research, as the technology continues to increase, as you do more and more, getting more information, the clinical side is saying, bringing these things to fore. So is the clinical driving the social, therefore ethical questions more than the social side about driving?
You're right. So all of these things were done because there was a clinical need for it. So it wasn't necessarily started to, as the evolution of genetic testing has happened, most of it has been that you do it for clinical reason, then you realize all the ethical, legal, social implications, the LC issues, and then people start looking at it. Having done the microarray, which came in practice in 2005, we realized that things like that are going to happen. In 2010, NIH came up with proposal. Now you can do exome sequencing, and the data that you get from exome sequencing is even more than the data you got from chromosomal microarray testing. So they wanted to be proactive. So they put in the proposal that we want there are these grants, and they wanted groups to apply for these grants and write proposals to identify best practices. So right now, it's hand in hand, but a lot of time, it doesn't always get looked at. And we're not even going to get a chance to talk about the other things that come. Access to care, that's such a big deal. And then that the social issue of it, we know that minority or underrepresented population, they don't have the same access of care as other people do, or because we live in Philadelphia, we have these amazing physicians and hospitals and technology available, but that's not the same case if you go 2 hours out to invest in Pennsylvania. So those issues, these things are all driven by clinical needs, but then we realize, well, this cannot work alone. There are so many more issues that come along with it.
So just a question, if somebody has cancer, did you say that in August of last year the insurance companies are now paying for this testing?
The August of last year, when I said that was for autism spectrum disorder, that the insurance company would do it. For cancer testing, the somatic testing that I talked about, the panel testing, some insurance companies would cover for it, some insurance companies still wouldn't cover for it. They still call it research, they don't deem it clinically necessary. The germline testing, if you have found, it's very interesting. So private insurance, some of the private insurance companies, if you have family history of it, they would let you have the test done. Some of the companies would say, I would only do it, especially CMS, we would only do it if you are the one who has had cancer and you want to do it for confirmation. It's like you want to do it for predictive reasons, not just after somebody's had cancer. This doesn't make 100% sense, but it's just people make these policies, and then they're really hard to change once the policies come into picture. One of the things that we're dealing with currently is that most genetic tests are what called lab developed testing. And lab developed testing historically has not been FDA approved. FDA said that you do not require approval for it. There are a lot of governing bodies, so College of American Pathologists, that accredits our lab, and they ensure the highest quality of testing. Various states have licensure, etc. But FDA, as the federal body, did not have same governance as they have maybe on some drugs, etc. This year they came up and they're like, no, we're changing it, and I think that the tests that have potential of harm, we want to make sure that FDA is actually approving them. So they're going to view it, and the clinical community is seeing it as almost a barrier, because FDA approves something that is very strict one-time thing, but the testing is evolving. As we saw in that picture, testing is evolving, and then getting approval from FDA is just such a lengthy, long process that's going to really stall the development. People are not going to get things in time, and then insurance companies are going to say, I'm going to only approve of the testing that is FDA approved and not of the rest. But these patients really need this testing done for diagnostic reasons. So we are really, really worried about that FDA regulation that are coming into picture. I don't know if I answered your question.
Yes, you did. Thank you.
Yeah.
Question to add to that. You mentioned how bioinformatics now, because there's so much data, you have to put this in a database. Is there a particular group that controls this database, or anybody can add to that?
Oh, it's just really interesting because, the whole question about intellectual property comes in, or because it's genetic data, and then, people get worried about if it is publicly available, can I be identified because this data is available publicly. So there are some databases that are public databases. So the one that I was talking about done on unaffected people, that is publicly available. One was for 6,500 people. The next one that came up is on 60,000 people, and that is publicly available. The clinical labs, when they do testing and they annotate all these variations, that data doesn't become public. But the scientific community is really trying hard to make this data public, so then there is some consistency. If one lab in Philadelphia has seen it, done all this work and figuring out what it means, the next time the next lab does it, they don't have to do the same. But then the intellectual property stuff comes into picture. So the data mining, we have so many different tools, and some requires licensure, some of them require limited access. So bioinformatics people, they help in bringing these tools together in doing the data mining. Anybody else?
I have just a generic question.
Absolutely.
I'm curious if there's been significant funding towards trying to study how the environment affects genetic expression as well. The field is termed epigenetics or something.
Right. There is definitely studies on the gene-environment interaction. We have talked about it forever, nature versus nurture, and not everybody expresses things the same way. There are a lot of studies, and Penn actually has a epigenetics center that they do the test, that they are doing research on. All of that is still in the research arena. It has not been adapted so much in the clinical setting yet. I'm trying to think. I know that there are a couple of examples where we are able to do it, but a lot of those examples are when this particular mutation, don't fuse flower beans, things like that is very limited numbers that are used in clinical environment. We know more, but that has not been translated in clinical practice. And there is decent number of funding, but it looks like all the funding right now, at least from NIH, is going into translational stuff. So basic science is suffering a little bit.
Okay, yeah, it was just a generic question because it's pretty clear that sometimes it's not that they have a genetic predisposition towards a disease, but it's actually the environment, something in the environment, perhaps something in the water, perhaps lead.
Right, absolutely.
Or mercury, or something toxic that they're being exposed to, and that in turn leads towards some genetic complication. But if they're not putting funds into trying to address the fact that there could be something toxic in the environment, then it sort of defeats the purpose, I guess, of this.
So sorry, I misunderstood your question. So there is some funding on it, and somebody recently gave a talk about they were looking at these very rare brain tumors, gliomas and glioblastomas, and they're talking about they know that the radiation causes it, but then they saw that there was more prevalence of it in some area in Texas, and then they went in to study why that is. So there is definitely funding into that area.
Is it Dallas by any chance?
I don't remember.
Anti-glioblastoma.
Oh, she
Dallas,
did?
Yeah.
Hmm. Some of that we know that some kinds of glioblastomas and gliomas are because of some specific germline cancer mutations, but very few. Most of them we still don't understand, and we have identified some markers that give you more risk, but it's still not to the point that is predictive in any way, shape, or form. And it's one of those conditions you can do so little. How much time do I have?
So it's right at 5:30 right now, so I don't know if you want to just summarize, and then people who need to leave can leave, and then if anyone has other questions after that.
Okay, so I want to, so I was going to go over some more examples of these incidental findings that we had identified, but I feel like, this goes at such bleak point that everybody gets worried and, you're going to say that don't do genetic testing. I wanted to put it a little bit in perspective, and these are some of the numbers that we have combed through, and these are from a couple of years ago, but how many times do we really identify things like that? And that's in less than 1% of individuals who undergoes testing. And with exome sequencing, maybe it's 5% individual who undergoes this testing. And it's not everybody. So it's not all bad, except that, I spend most of this time talking about all the complex issues. It's not all of that, that every time we come back with such kind of questions. The other thing that I wanted to talk about is the initiative to do responsible genomic medicine. What is being done? We identify all these issues, we identify the questions, what is being done. So President's Bioethics Commission recently came up with their recommendation, and they called it Anticipate and Communicate, and it was a 52 pages long, very well written document that was actually the dean of the medical school participated in it, in creating it. And what they came up with, that they said, well, you're doing this testing, going to find things, you need to start anticipating it. You can't say that, oh, I didn't know this could come up, because by now we know that you're going to come up with stuff. And how to deal with it the best way is by communicating it. One of the wonderful things that they had done, they broke down the findings in multiple different ways. When do you call it that this is primary finding? When you're doing the testing for a reason, you find the answer, that's your primary finding. Incidental finding is when the anticipatable incidental finding is when it's still unrelated, but you know that you can, just because you're doing genetic testing, you're going to discover something that's totally novel. You have unanticipatable incidental finding, the true incidental finding that you had no idea that you could discover and you still discover it. Rest everything else, everything that we talk about is called secondary finding. And then they went on to talk about, how to deal with each one of them and what are the best ways to do it. And we have spent a lot of time creating consent forms. And, we believe that consent forms cannot replace an actual informed consent discussion. The actual informed consent happens by somebody understanding everything. But the forms are really the document, is the place that the consent or the discussion gets documented. So we work really hard in creating it and, trying to not give too much information, but giving enough and making sure that people understand the risks and the benefits from the testing. But this was just something beautiful, as you were talking about, that it always seems like clinical stuff is far ahead and everything else is far behind. This was another way that, the Presidential Commission worked on it, and they realized that this is going to be needed. It's called Anticipate and Communicate.
Is that put by the Department USHH? Is that a government?
It is a government thing,
And
yeah.
so we could get that on.
I think so. I think it's available. If not, I'm happy to send a copy of it. What are the other things that are being done? There are a lot of the NHGRI initiatives, so the government initiatives. And they have the research, as I was talking about, that they had these research proposals that they wanted people to apply for, etc. what they are also coming up with, evidence-based medicine. It's really the buzzword around. You have to prove the evidence that when you do something that it really does result in intervention, and those interventions are really helping the patient. So the evidence-based medicine is what the buzzword is, and with all the healthcare changes, that's really what they want to see, and they're promoting it. And it makes a lot of sense. There is proven utility of any intervention that you're doing, and that's really what they are promoting. There are a lot of professional societies that are coming up with it, so they are doing their part in doing it too. So American College of Medical Genetics came up with the guidelines, and as we were talking about.
Oh, sorry. I have another question, which is, I guess, it's the same theme as the last question. So there's certain forms of cancer that are caused by certain biological agents, certain infectious diseases. For example, in females, there's cervical cancer, which is caused by that particular virus. So is there some funds that are going towards researchers interested in infectious disease and immunology? Because it makes sense to me.
Yeah.
But I guess in the field, like, sometimes things get lost. So infectious disease control is important for cancer control, cancer control, like management, I guess. But I guess if they're not making the link, which I guess is there, it's well established, then the funding won't be.
If it is already linked that establishes the causal relationship, then the funding comes in to try to figure out now how you're going to cure it. So there is always funding. I think infectious diseases specifically, it gets decent amount of funding, and things keep happening constantly, and they also have to look at it when you think about virus. They are constantly evolving, so they look at it. This is not my area of expertise. I don't know the details and the nitty-gritty of it, but our lab is in the Department of Pathology, and the pathology department has all kinds of diagnostic labs, and a lot of those are infectious disease lab, microbiology, virology, and our department head actually is a microbiologist, and he was the one who had worked with AIDS and looking at the receptor, and he had identified the receptor that helps with those individuals are not prone for AIDS. Actually, that's a good example of the question that you had asked, the advantageous mutation. So there is a whole bunch of funding, but I just don't know quite as much myself about it. So I'm just going to move quickly. So ACMG, American College of Medical Genetics, came up with their recommendation of when you should report. It was called incidental findings. Then what we should be calling now is secondary finding from these genome-wide technologies. And they said that when you identify something in these 56 genes that have very clear known relationship with conditions that you can do actually medically something, that you should report it out. So only the alterations that are going to actually are highly suspicious that it would cause something, and you can actually do something about it. That's when this information should be reported back. And then rest of the information, the families may still want to identify other things, and then the consent is required, and the families can choose they want other information or not. As I was talking about the evidence-based practice, there is a lot of public health initiative on genomic testing, and what they're looking for is prevent disease and improve outcomes. And CDC is doing their fair bit, and there is a lot of information. So to summarize, there are fundamental changes that separate genetic medicine from everything else. The complexity is only increasing because of the amount of data we get, and then the biological complications that come from just being genetic diseases. And really, this is a plea for everybody to understand that we are going to identify these secondary findings, and that communicate and have a plan, and that all the people really have the need for education to understand it. Genetic diagnosis is a powerful tool. I want to end with on that note, because I get worried when I start talking about these issues. But the ethical and social implications need to be carefully considered. We cannot not consider them because they are real and they're here. All right, so I do have a couple of cases. If anybody's interested, I can go back to them. But otherwise, they summarize. They're the same theme that we had been talking about.
Let's give Surabhi a hand.
Thank you.